This conference will now be recorded.
Hello, can everyone hear me? All right. Everyone hear me? Sorry about that. My microphone wasn't working, so I'm just trying this out. Thumbs up if you guys can hear me. All right. All right, perfect. Hello, everyone. How's it going? Welcome to another month here of EMS Journal Club. So we're going to be presenting an article today, and then also I have a couple interesting cases for you guys to kind of start off our day. Moving on here. So for our first article that we're going to be talking about, the only article, sorry. So again, this is me, MD80, Greg Dorilus. We're going to be talking about this article today about alternating fast and slow compressions rates during CPR to see if whether or not it actually improves hemodynamics. Okay. So, and the clinical question here is, does the change in compression rates actually improve hemodynamics during CPR? So we started off like we start with most of our articles when we're presenting, is with the PICO question. So the population here that's in question is they're using animal models for this. They actually use pigs. So the inclusion criteria for this was that they took 20 pigs and they anesthetized them, they intubated them, and then after that they actually induced a VFib rhythm. And then we'll kind of go more into the details on what exactly did. But part of the inclusion, they took 20 pigs, they sedated them, and then they induced VFib. So the exclusion criteria, there really weren't none. All the parameters were essentially controlled in the study. They didn't really outline any specifics on the pigs that were included or excluded from this, or what kept them from not being a part of the study. So the intervention obviously is going to be the time varying CPR intervals. And then the comparison is versus the conventional CPR with 100 beats per minute at a rate. So what they did is they basically hypothesized that the patterns of chest compressions varied over time would improve your outcomes in ROS and also 4-hour survival rate. So those are the two outcomes that they're looking at, whether they achieve ROS faster or what was your actual survival at 4 hours. So how did they actually alternate between slow compressions, which was described as 100 beats per minute, and fast compressions, which were 200 beats per minute. Sorry, 200 compressions per minute. Sorry about that. So the way they broke this down is that every 6 seconds they alternated between a rate of doing compressions at 100 and compressions per minute versus 200. So I had like a method on the actual rhythm. I was trying to get the audio so it kind of played for you guys so you guys can imagine. Basically, when some of us, when we do compressions, there's that song that goes along, keeping hope alive, and you're like compressing the chest like that. So you can only imagine at 200 compressions per minute what that would look like. So moving on to here, so the reason why I have this diagram up is to actually show the type of pig that they use. So they used the Yorkshire pig. This were the pigs that were actually analyzed in the study. In case you didn't know, there's a whole bunch of other pig species out there, but for this study, they used the actual Yorkshire pig. So moving on to like the PICO question, so the outcome. So the outcome, what they basically found during their study is that time varying CPR improved the proportion of the ROS over time compared to control. So ROS was achieved 9 out of 10 versus the 5 out of 10 in the regular control group, which used conventional 100 compressions per minute. And then the 4-hour survival was higher in the time varying CPR at 8 out of 10 versus 5 out of 10. But they did not differ significantly between groups. So what they saw was during CPR, coronary and cerebral perfusion pressures and the femoral artery pressures, they weren't really different between the groups, but the end tidal, the mixed venous, and the saturations were higher in the time varying CPR group with a p-value that was actually statistically significant with less than 0.05. So they saw that between switching the compressions from 100, it actually improved the coronary perfusion pressures. And then when they switched to 200 chest compressions per minute, that favored cerebral perfusion pressures. All right. So just to kind of repeat that, because that's going to be the trend. So a normal conventional CPR, 100 compressions per minute, that favored more towards increasing your coronary perfusion pressure. And then switching back and forth to the 200 chest compressions per minute, that favored cerebral perfusion pressure. Okay, moving on. So the author's conclusion. So again, time-varying CPR improved the hemodynamics and the indicators of Ross compared to guidelines. The study yielded multiple indicators of improved hemodynamics despite spending 50% of CPR time performing chest compressions conventionally, which were thought to be ineffective. The concept of time-varying CPR opens a potential new avenue for CPR research that could improve the efficacy and the outcomes. And obviously, future work should focus on understanding the mechanisms leading to the observation and to the benefits. All right, so just to kind of break this down even further, they took 30 pigs. They were randomized into 3 groups. And I know before I said there was 20. So they also did another study while they were conducting this one. And they're basically doing a study where they're looking at a stuttered group. So that's where the other 10 pigs came from, but that's not discussed in this article. But just to kind of show you guys the transparency, 30 pigs were actually selected and broken down, randomized into 3 different groups. But for our study, we only used the 20. So they were pre-medicated, anesthetized, like I said, they were intubated. Before the VFib was induced, they measured their end tidal, their temperature, their CVP, aortic pressures, mixed venous, pulmonary artery pressures. They even had swans in these pigs. They also measured intracranial pressure. And so prior to inducing the cardiac arrest, they sent out venous and arterial blood samples to look at the electrolytes, the pH, the hemoglobin, etc. So then they sent the blood work out every 5 minutes during the CPR while the compressions were actually taking place until Ross was achieved. So the way VFib was kind of induced, they actually had like a current and they put it into the RV, and once they induced VFib, they let the pig sit there 10 minutes without any CPR was performed on them. So in the conventional group, which is 100 chest compressions per minute, after 10 minutes, they were defibrillated, epi was given, went through the whole entire algorithm. And the way we define Ross for this study is that you had to have more than 3 contiguous beats with peak systolic aortic pressures greater than 50. So the experimental group, group 1, again, the conventional, group 2, the time-varying CPR, they alternated the chest compressions every 6 seconds with doing 20 compressions at 200 chest compressions per minute and then versus the 100 chest compressions per minute. Okay, so they found that there was no significantly differences between the control and the time-varying CPR groups in the blood samples measurements are calculated the arterial shunt fraction. So neither did they observe significant differences between the groups for pulse Ross, even with epi, or the aortic pressures. They didn't really change much. Okay. So moving on. All right. So this was a chart here of the primary outcomes that we're showing here, just kind of based on the numbers and stuff that I was showing you before, and pay attention again to like the p-values, see whether or not they were significant. And then over here as well with the graph. All right. So the secondary outcomes. So they looked at the hemodynamics versus time and hemodynamics versus rate. So the hemodynamics is kind of what I touched upon earlier. So they were comparing the time for the first 5 minutes of CPR. So the CPP and this coronary perfusion pressure and the cerebral perfusion pressures, they didn't differ between the groups. But again, during conventional CPR, it favors more towards coronary pressures, and the time varying CPR, it favored more towards cerebral pressures. So although the time variable CPR did not improve the time course of coronary perfusion pressures, it did lead to an increase in the end tidal and the mixed venous, which actually favors more, showing that there's more forward blood flow. And if you have more blood flow going through, it is actually leaning more towards improving your patient outcomes. So the decrease in the pulmonary artery pressure that they saw with the time varying CPR versus the control, that was actually noteworthy for you to kind of see, because if you have a low pulmonary vascular resistance, that effect actually is mediated by the receptors that are there, and it causes a hypoxia of pulmonary vasoconstriction, which will then in turn lead to a higher mixed venous. And that will help with achieving Ross. So past studies, when they were looking at the chest compression rates, there's never been a study like this who actually checked chest compression rates as high as 200. They've done 20 to about 150. So one study found that blood flow that was significantly impacted by chest compression rates between 60 to 150 was more dependent on the duty cycle. But in contrast to the two studies that were looking at rates at just 150 chest compressions per minute, that actually resulted in a reducing your cardiac output. Obviously, you can imagine if you're compressing your chest at 200, chest compressions per minute, you're not giving the heart enough time for it to fill. And so that's why I think you're seeing the results where they're saying through conventional CPR, that favors more towards coronary perfusion pressures versus when you're actually doing 200 chest compressions per minute, that's very more towards your cerebral. So the study is basically saying if you do more compression, the faster you do your compressions, it's going to favor more towards a neurologic favorable outcome versus if you're doing it the conventional, where it'll favor more towards a cardiac standpoint. All right. Moving on. So here again, this is kind of like the charts and graphs that were showing like all these different variables here between the two groups. So the CPP is your coronary perfusion pressure and the CEPP is your cerebral perfusion pressure. And you actually see the difference here where they're favoring, each one of the groups that I previously mentioned. Okay. So here we go again, and this is them looking at the other variables here, your end tidal, your pulmonary artery pressures, your FEM pressures, your mixed venous. So now what were the limitations to the study? So basically, again, when I was going over like the inclusion exclusion criteria, I mean, they basically selected the population. They took healthy juvenile porcine model pigs essentially, and they induced everything. So that was kind of one of the limitations there. Even though it was randomized in these two different groups, but they were, hand selected. The study was not powered to conclusively show an increase in ROS or survival, given the observance rate of 50%. Again, the study did not have a group that received only 200 chest compressions per minute. The treatment group, they did the time varying where you were getting conventional CPR versus then increasing it to 200 chest compressions per minute. But they should have had another group where they looked exclusively just at, the pigs that were getting chest compressions at that specific rate. Okay. So kind of going through into our randomized control clinical trials questions. So did the study population include or focus on those that were in emergency department? I put yes. So basically, I mean, the study wasn't done in the ER. It was mostly done in like animal models, but still this is like a study population that we can apply to our population. Any patient who's in cardiac arrest would apply. So the patients were adequately randomized. They were randomized. But again, I would have really liked to have seen that third group be used where they actually looked at just doing chest compressions at 200 compressions per minute. The randomization process was concealed, yes. The patients were analyzed in the groups into which they were randomized, yes. The study patients were recruited consecutively, yes. The patients in both groups were similar with respect to prognostic factors, yes. All participants were unaware of the group allocation, yes. The groups were treated equally except for the intervention, yes. The follow-up was complete for at least 80% in both groups, yes. So the follow-up was up to 4 hours. All patient important outcomes were considered, yes, and the treatment effect was large enough and precise enough to be clinically significant. And that's like a yes and no answer, because obviously coming down to like the p-values and all the other things that we kind of touched upon before. So the discussion. So like I said, this is kind of like the first study that we've seen on this level where they were doing basically looking at changing the chest compressions quality and the rate. And we really haven't seen anything like that up until now, except for that other study where they went up to 150 chest compressions per minute. But again, I think it all leads into the thing with cardiac output is that the faster you do your compressions, you're not giving the heart enough time for it to fill and kind of pump it back out into the system, and that there probably would lead into issues. All right, and then so thoughts. All right, everyone's kind of muted. If anyone's talking, everyone's muted. I can't hear anything.
Hey, Greg, I think the biggest question I have is, what way do you think that the study talks about something that is is this early research? Is there anything directly useful for the providers on the ground? Would you change anything that you're
No, I
doing
mean,
or
no,
thinking about other things to look at? Or
no, I definitely think based on this study, I wouldn't change anything that we're kind of doing right now. I think it's definitely gonna take some time to see. Like I said, I'd be interested to see what happens if they actually took one of these models and they looked at just solely doing compressions at a rate of 200, chest compressions per minute. I think the other thing is that other study where they looked at going up to 150, where so the outcomes there might have been somewhere in the middle ground, because I think 200 is too fast. I think 100. I mean, obviously we have studies and there's literature that supports doing the 100, but I wonder what if you meet in the middle to 150? What exactly would happen? And then also you got to think about how feasible is this? How are they going to do it? I mean, are they doing just manual with an actual device where they're doing this, or you can imagine when you're on the ground and you don't have like a Lucas device and you're going to be relying on other personnel to be doing these chest compressions. We have courses where we have to teach BLS just how to do compressions effectively. Now, if we have to change our whole entire model and kind of going into something else and teaching now providers how to increase, their compression rates and the depth and all that research, I think there's so many other variables that are still in play here that need to be figured out.
I may have missed this, but how did they calculate again that somebody was going to, like it was at 100 versus, 200? Like was there impedance device or something like that? Because, I mean, historically, when we see people do CPR in the field and even in the ER, either they're going a lot slower than 100 or they're going, 120, 150, and you're trying to tell them to slow down.
Yeah, so they didn't make mention of how they actually measured it or if there was any devices there. So what it seems like, it's like they were basically, because it's time variable, so every 6 seconds, I guess they had a device on them that was telling them it's going to be 100 chest compressions that are going to go for 6 seconds. Then they changed it after 6 seconds to change the rate to 200, so they were just compressing even faster. That's what it made it seem like to me when I was reading the article. But they didn't do it continuously. It's basically just time varying. Every 6 seconds at a rate at 100. Then you switch it to 200.
Did you happen to mention if it was manual compressions or did they use a Lucas device or something similar?
So they didn't say it was manual. My guess, because it was on pigs, I mean that they used the device. There's nowhere that was mentioned that it was manual CPR, but I think they used the device.
Yeah, I think for practicality in the field, the only way this would ever work would be with a programmed device.
Yeah.
And I think when I looked at it, I don't remember, was it sponsored by Physio or one of the companies?
Yeah, I think it was sponsored by Stryker.
Right, Stryker, who owns Physio, who makes Lucas, so that kind of makes sense.
Yeah.
which may be the only one who can go up to 200.
Yeah.
So the other thing is, we did have that study a couple of years back where they showed that, about 100 is the optimal for good outcomes to neurological good outcomes. But, with this study, this opens the door to more research where, maybe if we look at this more, maybe this is the difference. But this is still very, very early. This is even earlier than the heads up CPR stuff, which, the advocates of those articles have also said, like, this is not ready for prime time. This is just something to think about, and hopefully we can get some good evidence before we actually put this into practice. All right, should we move to the case presentation?
I mean, the only thing I would, can you, oh, is this on here?
Yeah.
Oh.
Talk about it.
Oh, the only thing I would say is, like, this is just in line with, like, kind of what we're doing as far as just so many different opportunities and different ways to do, resuscitation on cardiac arrest. And this is clearly to where, the same point. We don't know what we're doing, and it's going to be a long while before we get the perfect, way to resuscitate a patient. This is a new trend. Looking at, incline, resuscitation as well is going to be the new wave. In different degrees of inclinations of 15 to 10, versus supine. So looking, at cerebral perfusion pressures is going to be huge. And I think ultimately we're going to come down to a science of, how long do we resuscitate patients before we lose that cerebral perfusion pressure? And I think ultimately, we have to make a decision of what is it that we're trying to save, And I think, so many people lose sight of the fact that cardiac arrest, we need to save the brain. If you don't save the brain, what's the point of saving the heart? And so, people have to shift that focus. So people are so focused and hyper vigilant on resuscitating the heart that they lose focus of the brain. And so I think now we're seeing lots of people moving in a direction of where, how can we do appropriate resuscitation of the brain during cardiac arrest? And that's such a huge point that it's so noteworthy. And I think that we're hopefully moving in the right direction, and there's going to be so much more to come. And I think that's what's really nice about this article, is that we're thinking outside the box and we're saying, what else can we do different? But what else can we do different for the heart? What else can we do different for the brain? And that's what's so important. Thanks, Chris.
Yeah. And even like I think you've mentioned it before, is they're looking at all these new things like with REBOA or partial REBOA, to kind of keep the perfusion pressure to the brain as well. So I think we're definitely going to see a lot more of that, and maybe some other things that are not REBOA that we could actually use in the ER in the field a little bit more often.
Yeah.
All right, so thanks everybody. So we're going to be moving on to the next part, which is the cases portion of it. All right, interesting cases. So this is going to be kind of a wide range of cases that happened during one of my clinical shifts throughout the month. So I could kind of themed it. It's kind of welcome to the Heartbreak Hotel. With the theme, I guess it's going to be something cardiac related. So what you're going to be looking at here, sorry, just trying to put the video here. All right, so I'm going to show you guys several different EKGs here. Hopefully those of you on video, you guys can kind of see this, or those of you on mobile, hopefully you can see my presentation. But you're going to kind of see, I guess, a constant theme here. So this is EKG number 1, all right? EKG number 2, all right? EKG number 3, all right? And these are EKG number 4. So all of these EKGs, just going back through it, all represent different people, all on the same day, okay? So we'll kind of move into the cases now, just to kind of give you guys an overview and say. So case number 1, so you guys have a 71-year-old gentleman who came in. He has a history of, CAD, he has stents, high blood pressure, diabetes. So he was brought in with the medics because he had like a syncopal episode while he was at home. He had LOC, he hit his head, had some head trauma. He was complaining of some heartburn, some chest discomfort, pain in the back of his head. But in the field, they found him that he was actually hypoglycemic and he was hypotensive. So his finger stick in the field was 30. They gave him some PO glucose, they gave him some nitro, and they gave him some fluids, and then they brought him in. All right. So these were his initial vitals when he came in. Right, normal blood pressure 139/73, heart rate 82, low tachypneic at 29, pulse ox was 99% room air. Okay. So this was his EKG. All right. So this was his EKG that they brought in, which was the same that they did in the 12-lead out pre-hospital. All right. And so when you're looking at this EKG here, I guess what you're hearing that story, very commonly we hear people always say, oh, I thought it was just heartburn, just having a little bit indigestion. But obviously when you're looking at this EKG here, it actually looks concerning. So the thing that's concerning about here is that you do see that there is some ST elevations in the inferior leads to begin with, right? So 2, 3, AVF, right? And so you also see some in your lateral leads. mostly like V4, V5, V6. And then you see the depressions as well in V2, and slightly, I guess, in V1, if you'd call it AVL, right? So this is kind of consistent with a STEMI. So this patient is actively having a myocardial event, leading with this history, 71 years old. You know, yeah, he was found to be hypoglycemic in the field, and that's probably why he had a syncopal episode leading up to it. But then, you know, consequently, I guess he's also having a STEMI. So we activate the code STEMI, and the cardiologists come down. They're asking him all these questions, and then they're kind of making a decision on whether or not they want to take him to the cath lab first. Want to take him to the cath lab. So they did take him to the cath lab, but before taking him to the cath lab, because of what I said, the history about him falling and passing out and hitting his head, and that's kind of there documented. One of the things you want to make sure is, because as soon as we activate a code STEMI, you know, most of the times for those of you pre-hospital, I'm sure they do this in their field too, the cardiologist wants you to give aspirin right away. They want you to give some type of antiplatelet, Brilinta or Plavix, mostly Brilinta, or they want you to also give a flush of heparin, you know, 5,000 units. So what would be the concern of kind of pushing all those medications here, given that history? Is obviously, I mean, if you have this patient has a history of minor trauma, and not really a trauma, but, you know, syncope episode hit his head, you want to make sure he's not bleeding in the brain before you actually do this. So the reason why this case is kind of important here is that knowing that although we have the diagnosis, we know exactly what it is. It's just not to rush to kind of push and give, you know, all the medications stuff, because the cardiologist is like, all right, give him all the medicines and stuff, but then you have to wait, sit there and actually think, what if he has a brain bleed on top of that? So we did hold the medications before bringing him to the cath lab, make sure his CAT scan of his head was normal, which it was luckily, and then we were able to give him the medicines on the way to the cath lab. So what did the cath reports show? So judging based on the location of where this is here, you know, and the elevations in 2-3 AVF, the inferior leads, and also in the lateral leads, you know, I was going to say, where do you think the lesion would be? So moving on to like the cath report. So the site of intervention was the proximal RCA. So they found a 95% occlusion that was there. They had a 95% occlusion. So basically, like I said, he had stents already. So he has a subacute stent thrombosis in his proximal RCA, which corresponded with obviously the inferior STEMI. They also did a primary mechanical thrombectomy where they aspirated some blood clots, and they were actually able to restore complete flow to the vessels. So this patient did well, was discharged after 2 days, and he went home completely fine. Okay. So next patient. So this one, the triage note says the patient came in, chest pain, dizziness, headache for 1 week, history of just hypertension. 52-year-old guy, no past medical history, coming in with chest pain and headache. So he said he started having a headache since 4/19. I guess it's 4/24 now, so almost a week. He reports he quit smoking, but then he started again after a divorce because he went through a rough patch. And then around 1 p.m., the chest pain became really bad, which made him want to come to the ER. Oh yeah, he also had his first dose of his Moderna vaccine 2 weeks ago. I know you're kind of reading this and you're like, oh God, maybe this is going to be the common trend, what's going on here. But I'm here to tell you that the vaccine had nothing to do with this. I hope. We'll find out soon in a couple years, if anything. So that was the story. This is his vital signs here. So he is actually hypertensive. He's 184 over 114. His heart rate is 63. His respiratory rate's 18. His temp's 97.7. So besides the hypertension, you know, everything there is okay. All right. His oxygen 97%. So this is his EKG. So chest pain and headache for on and off for about a week. You can imagine, on and off for about a week. And he just comes strolling into the ER saying that, yeah, you know, it's just been bothering me more than usual. And then, you know, you put the 12 lead on him, and this is what it's showing. He was a walk-in. He wasn't even pre-hospital. He came in because, you know, when I asked him more about the story on, you know, why you just, because he had never come to the hospital before. And I was like, why did you come to this hospital? And he's like, oh, my sister used to work here years ago, and she told me that this was a good hospital to come to if I ever had issues with my heart. And so he was like, you know, something just wasn't right, and he decided to come in. So here, his EKG is definitely much more, I mean, it looks more concerning than the other EKG that we saw prior, but this is very significant. And I mean, this kind of jumps out at you. You're not really going to miss this. So you definitely see the elevations, kind of looking here in 1, AVL, V4, V5, V6. You also see it in V2, V3, and you see the depressions in the inferior lead. So this guy's having a massive STEMI after possibly like a week. And his only history that he knows, he doesn't even say he has high blood pressure. He said he just smoked more than 1.5 packs per day for more than 30 years. So that was the only thing that he did. He just smoked a lot. So again, he went to the cath lab. He winded up having 100% mid-LAD occlusion. And so for those of you that know, the LAD, we call it the widowmaker because, you know, if you occlude your LAD, I mean, that's one of your main vessels of your heart. You should essentially just drop dead. And then this guy's walking around for a week with having chest pain and a headache, and he had 100% occlusion of his mid-LAD. So for him, they were able to put a stent, they were able to put a stent in. Sorry, he actually had also a left circumflex. They said it was about, the cardiology told me it was about 80% stenosis. So he had 100% LAD, and he also had like an 80% of his left circ. And this guy also did well, and in 2 days he was discharged home. All right. So the next EKG that we're doing here, story, I should say, the next story. So this gentleman, the triage note, he was brought to the ER by paramedics for high blood sugar. He was reading high in the field. He wasn't taking his metformin at home all day and was at work, and he vomited, and that's why they called 911. So he's 59 years old, history of just diabetes, high blood pressure, brought in for elevated blood sugar and weakness, felt dizzy at work, vomited, called ambulance. He also has upper back pain since last night. And he reports that, you know, he's on metformin, but he hasn't been taking it. You know, it doesn't take it like he's supposed to. And in the field, his sugar was just reading high on the glucometer. Didn't even give a number. Okay, we get this patient coming in. Oh yeah, by the way, this is his initial vital signs. So he was hypotensive, 60/48 when he got here. His pulse was 69. His room air sat was 90% as well. Okay, so you have someone coming in from the field who's not only hyperglycemic, right? He's hypotensive and he's hypoxic. And he was complaining of vomiting and he felt dizzy. So before kind of moving on and going through your entire medical management here, the first thing you hear about this, whenever you hear any patient like this, is like, wow, you know, he must be in DK, right? You must think that might be like the number one thing that pops up. It's like maybe he's in DK. He's severely DK. I mean, he's so hypotensive from it. So then, you know, the medics, they do their 12 lead in the field. And so, sorry, moving on to the exam. His exam, basically, he was very lethargic. He had dry mucous membranes, basically looked very weak. So this was the EKG that we got, which was consistent with the same that they did in the field. So I would like somebody to kind of take a look at this EKG and interpret it, you know, if they can. And you've seen so far 2 other EKGs that were clear cut and they looked like a STEMI, like the stories fit that they were having a heart attack. And so now you're getting this patient who's in front of you, who's possibly in DKA, he's hypotensive and he's hypoxic, and they hand you this EKG. So what would be the next course of management in this? What would you do with this EKG?
Was he having chest pain? Just nausea and like abdominal pain?
Yes, and chest pain.
Okay. I mean, he's got a history of diabetes on metformin, whether he's taking it or not. I mean, he's got a prolonged QRS. I mean, initial thoughts would be like hyperkalemia, renal failure. I'd at least, you know, give him bicarb and calcium and go from there, especially with his blood pressure so low. And then if it's still not normalized, then worry about a STEMI.
Yep. All right. Good thought. Because so kind of looking at this EKG when I got it, I mean, again, this is like the theme of the day. All these patients all came in at the same day. And you're looking at this and you're like, wow, you know, this possibly could be STEMI. But also he is just so hyperperfused right now. He's hypotensive. He's not even tachycardic. I don't even know. He doesn't have much of a reserve, but he's hypoxic and his sugar's really high. So my thought is that maybe he is hyperkalemic. All right. So this is not the order of the events of what happened, but the labs obviously were sent off way before. But here are the lab results. So he had a white count of 16,000. Definitely had it with the left shift. His electrolytes, so sodium's 124, his potassium is 6.4. It wasn't hemolyzed. His bicarb is 9. His creatinine's almost 3. Bilirubin's elevated. His lactic acid is 8. His beta hydroxybutyrate, which is ketones that we use, one of the ketone tests that we use here to detect for DKA, was elevated. And his LFTs, his liver function tests, they were elevated. Okay. And then what everybody kind of wants to know, COVID or not? No, it wasn't COVID. COVID was negative and flu was negative. RSV was also negative. All right. But his troponin was 73. All right. Which is significantly elevated. Our value here at the hospital I work at, it's anywhere less than, the normal value is less than 0.15. And here we're looking at a troponin where the whole number is 73. Okay. So basically what you could kind of see here, this looks like a multi-organ failure type picture. The patient's definitely in DKA. He has an elevated anion gap that he has got going on. So here is another EKG. And so before we kind of go back into this EKG, I want to kind of walk you through the chain of events of what happened here. So he came in, obviously we identified a sick critical patient. His finger stick was reading high. The next thing that we kind of did was that the patient was treated with 1 gram of calcium, given the wide complex QRS and the hyperglycemia, and that we were concerning thinking about DKA. We also initiated fluids kind of right away. So the reason why, the decision was made to give him calcium was that what if he is just hyperkalemic and it's causing a wide rhythm, and maybe this is a sine wave for those of you that know what a sine wave is. That's what we were looking at, and the patient is essentially about to crash. All right. So after we gave him the gram of calcium, that was this EKG. Okay. So this is the EKG after the gram of calcium. So just to remind you guys, this is the EKG from the gram of calcium, and this is the first EKG. Okay. So this is the first EKG, second EKG. Is there much of a change?
Looks worse.
Yeah, exactly. So these EKGs were taken 15, 20 minutes apart. And so most of our patients who come in with a concerning EKG, we like to get serial EKGs on them, every 10 to 15 minutes. So we were doing that for this patient. So this second EKG, it definitely does look worse, but there is definitely signs here of elevations and the depressions. And with the way his picture is, and he's saying he had chest pain, at that point you have to kind of activate a code STEMI and kind of get your cardiologist involved to take a look. So the course of events, what we did here, so we did a cardiac ultrasound in the ER, and basically we noticed that there was no motion of his anterior septal wall, and he had like a reduced EF. So we also started the patient right away on a pressor, started on levofed. He did complain of upper back pain. So the other thing you have to worry about is chest pain, upper back pain, and a hypotensive patient, with all these comorbidities for it. You have to think that maybe he's having a dissection, because quite infamously enough, and I've seen it a handful of times, we get an EKG, we all get excited, start high-fiving, it's a STEMI, it's clear cut, they take him to the cath lab, and then you hear a code blue from the cath lab because the patient actually had a dissection, and when they were getting ready to do the cath and put in the wires and everything, they happen to just make the dissection worse and just tear right through. It's happened. So, with us, with the thinking that we had is that before you take this patient to the cath lab, he's very, very critical. You would have to do a CTA to kind of make sure that this isn't a dissection you'd miss, because although he's unstable, you're stabilizing him with starting him on pressors and fluids and kind of give him calcium and bicarb to try to get him over to the CAT scanner. You want to make sure that he doesn't have a dissection before taking him to the cath lab. And so at this point, the cardiologist is already at the bedside and they kind of agree with the plan. Okay. So immediately, kind of after the CAT scan was done, it showed there was no dissection, by the way. The patient actually went agonal on the CAT scan table and he went into a cardiac arrest. So while he was on the table, so they call code blue overhead. A whole bunch of people rush over. So basically, chest compression started. He got a couple rounds of epi. He was intubated there on the CAT scan table, and we were actually able to get him back. And then he was immediately brought to the cath lab, which is where he needs like his definitive treatment and the definitive management. So you already cleared that it's not a dissection, so they can kind of go in and do their thing. So when they get to the cath lab, so here's the kind of report. So there's 100% lesion occlusion of his LAD, again the Widowmaker, and also 70% of his left circ. So he had the same findings of the previous guy, the guy who had chest pain for like a week, right? So while he was actually there on the cath table, again, he actually went into cardiac arrest a second time. And they had to do chest compression on him while they were actually doing the cath lab. And then the decision was made to place an impella. So they actually put a device, a circulatory support device, into his groin so that they can help sustain him and kind of, bridge him to find out what other, treatment options he's going to need after it. So he did survive after the cath lab, and they brought him up to the CCU. So I can tell you, just because I've been following the case just to finding out how he's doing. So that same night, they had to upgrade the amount of pressors he was on. He then became maxed out on 4 pressors, completely maxed, and it still was not enough to kind of hold him over. And he was not able to, he didn't have any reserve essentially. And they talked to family and they did make him DNR, and then the next morning he did pass. So the reason why I want to do these as the interim cases, not only that these are all real cases, but these all happen all on the same day. But I just want to show you guys how the difference of patients on, all of them presenting with kind of the same thing. Let's say chest pain was the most common complaint, but how they all could have very different outcomes. Where you have those who are stable, who just walk in and have a STEMI, versus those who come in with the ambulance having indigestion, versus the other ones who come in very sick and kind of, unfortunately waited too long, or, they're just very sick and their comorbidities, complicated things, and unfortunately succumb, to their injury. So those were the interesting cases for this month. And then the other thing I kind of want to touch upon. So last week I actually had the privilege, I was away on assignment. So I went to New Mexico. For those of you who've been, I don't know if you've ever been there. New Mexico is a very interesting place, but I actually went and I attended a FEMA course. It was the PRSVI, it was the Prevention and Response to Suicide Bombing Incidents. So I basically it was all expense paid for through FEMA. It was done in New Mexico Tech. And so for those of you that don't know, New Mexico Tech, it's actually one of the top 10 engineering schools in the world. I didn't know that. I had no clue. When I went there, they basically told me that this was a school where if you don't get into MIT, this is probably the next best place to go. And I was like, wow, in the middle of New Mexico, because it literally is just a desert. We weren't in Albuquerque, which is the city. You're like an hour and a half south of Albuquerque. And it's basically a very small town where there's only like 5,000 people population, but it's just this school that's there and it's all desert. And this is, I guess, is the best place to kind of, set up shop if you're an engineer. So I got to spend a week there. It was a great experience. I got to meet a whole bunch of people and kind of learning about how to respond to these certain types of incidents, especially with the way that the world is kind of going right now. If you guys definitely have an opportunity to, I definitely recommend you guys should take something like this. It doesn't have to be this course necessarily, but they have tons of courses down there. It's a great experience. And like I said, expenses were all paid for. It was a great opportunity. If any of you kind of have any questions about it, you guys can obviously message me directly and I can give you more details about it. Right now, actually, Dr. Lynn is there. Brian Lynn, he's actually there doing it this week. And I think Emerson is going later on next month. But yeah, otherwise, that's all I got for everyone today.
Dr. Dorilus, was that the one where you get to blow stuff up?
Yes, it is. I didn't want to say that, but yes, that was the one where you get to blow stuff up. It was a great, it was a great time of learning, the ins and outs of, the things that you can mix to blow stuff up essentially, and it doesn't take that much. it's kind of scary when you really think about it. And you're like, if a lot of people had this intel, the world would be a very dangerous place.
And now you know why you can't take water onto the airplane.
Yeah. Nope.
Yeah, the big thing for the case studies that, you know, the takeaway is that, you know, it doesn't all present the same. Someone with like just, you know, the patient that we see all the time with reproducible chest pain or something like that, they look completely fine. You do an EKG, it looks crappy. They can still be having a STEMI, and a pretty bad one. So.
So was that last case, you said it came in by EMS.
Yes.
What was their impression or working diagnosis?
So the EMS actually, they called ahead and they activated the code STEMI. They said that this is a code STEMI based on that EKG, the first EKG. And so they interpret the EKG right, because the EKG does look, I mean, it definitely does look concerning. There is elevations there and it is a wide complex, but kind of with everything going along with the high blood sugar and he was already hypotensive, you know, we see it very commonly when you're so hyperperfused like this, your EKG can look very funky and not look like an organized rhythm. But you have to also wonder if maybe if you stabilize the membranes with calcium, would this change, you know, the rhythm?
Okay, great. Thank you.
Yeah, but they correct.
That'll be a good case presentation is the effects of hyperkalemia on the EKG.
Right.
Because we've all had cases like that where the EKG is very similar to this, and you push a gram of calcium and you do a repeat, it's back to normal.
Yeah, she did.
All right, I think that's it for this edition of Journal Club. The next Journal Club, I just have to pull it up. Emerson, I think you're doing Journal Club next?
I think it's May 12th.
Yes,
May-
May 12th.
Yeah,
I'm on
Dr. Lynn,
vacation May 12th.
yeah, it's Dr. Lynn. Dr. Brian Lynn will be doing it.
So Dr. Lynn,
Yeah, I
May
do something in
12th,
June.
12 p.m. Same link. I'll see you all there. If you have any interesting cases or something, you know, send it over to me and we'll go from there. All right.
Great. And Dr. Nevin, if you can just share the recording, we'll get it posted on Workplace, or you can even post it on Workplace just so people can view it.
Absolutely. All right.